Hi, everyone, and thank you for joining us for today's webinar, Getting It Right, Drug Pricing Reform that Works for Patients and the Medicare Program. My name is Sue Peshin, and I serve as President and CEO of the Alliance for Aging Research, the leading nonprofit organization dedicated to advancing research and improving healthy aging for all. The Alliance is co-convening today's event with the USC Schaeffer Center for Health Policy and Economics. The Schaeffer Center is a collaboration between the USC Price School of Public Policy and the USC School of Pharmacy, whose mission is to measurably improve value in health through evidence-based policy solutions. For those interested in learning more about our organizations and funding sources, you can visit our respective websites. We have enabled live transcription of this webinar, and you'll see a notification about closed caption live transcript at the bottom of your screen. And we posted info here on how to turn closed captioning on and off. Throughout today's discussion, we encourage you to use the Q&A feature to submit questions to our panelists. Submit your question at any time. And as we move to the final portion of the webinar, I'll pose as many of these questions as time allows to our panelists. Our first speaker is Congressman Scott Peters. Congressman Peters serves California's 52nd Congressional District. First elected in 2012, he currently serves on the House Budget Committee and the House Energy and Commerce Committee, as well as the Joint Economic Committee. Representative Peters' emphasis has been on promoting and expanding San Diego's innovation ecosystem, advocating for San Diego's pivotal role as a partner in the national defense, and making government work again. 1 month ago, Representative Peters and Representative Kurt Schrader from Oregon introduced the Reduced Cost and Continued Cures Act, or the RCCA, which the Alliance supports, to lower patients' prescription drug costs and protect our nation's ability to find cures. The proposal includes an annual cap on out-of-pocket costs for seniors, as well as provisions to address loopholes in the healthcare system and reduce the cost of drugs for the Medicare program. Congressman Peters, thank you so much for all the work you've been doing. Welcome, and thanks for being with us today.
Thanks so much for having me and for the chance to talk a little bit about drug pricing reform and where we are in Congress. Let's start with an understanding that it's wrong for seniors to have to choose between paying their rent and affording their medicines. I think every Democrat actually would like to tackle that. I think a lot of Republicans would as well. Obviously there's been some discussion about what's the best way to do that. The Democrats' proposed bill from last term, which we call HR 3, that's the number of the bill, would put a cap on the amount that seniors could pay at the counter and would put a cap on the amount drug prices could be increased from year to year. But it had one thing that I had a problem with, which is the negotiation regime that they suggested would set a reference price based on international prices, could be a different reference price, but would say to companies who produce these cures, take our price or we'll take 95% of your profits. It's a 95% excise tax. I expressed concern last term and in the past that that's a pretty strong signal to investors that you may put all this money at risk to develop these cures, but you also may not be able to get a return on that money. We thought that there was a real concern. We had a real concern that it would dissuade people from investing. Now, why is that important? The development of drugs is a partnership of the public and the private sectors. So in my district in San Diego, we rely heavily on the National Institutes of Health to fund our scientific research institutions. We have the Salk Institute, Scripps Research Institute, Hoya Immunology, Sanford Berman Previs Cancer, UCSD. All of them compete for funds from the National Institutes of Health, NIH, to do basic scientific research, not directed toward creating a product, but really to understanding the basics of science and chemistry that affect people's health. I'm one of the biggest advocates. I'd say there's no bigger advocate for the funding of NIH than me. I mean, there's a lot of us, but none are more ardent than me. And since I've been in Congress, in 2013, I'm proud to say that the budget for NIH has gone from about $29 billion to over $40 billion. And that's so vital for our science ecosystem here. But NIH doesn't develop products. That's left to the private sector. And if you think about the investment that the federal government made in the internet years ago or in GPS, taxpayer money had a lot to do with inventing those things, but we don't commercialize them. That's left to the private sector. And if you think about the role of the private sector, sometimes it's poo-pooed, but in 2018, the private sector invested $102 billion in research into life sciences. Now, again, $40 billion from the NIH, that's a lot of money, but it's dwarfed by the private investment. That money comes in as risk capital. It's totally without risk to taxpayers. And we taxpayers don't pay for anything until at the end it's certified to be safe and reliable by the FDA. So there's no risk to taxpayers. But the cost, it is risky because the cost of a drug that's successful costs about $1 billion to get from beginning to end. And if you count for failures, it's more in the lines of $2 billion because 95% don't make it to market. So this is very important for us to preserve. And if you dissuade those investors from taking that risk, we face the possibility that those cures won't be there at the end. We heard from a number of investors, not the big pharmaceutical companies, but the people who actually put risk capital up, that if you did this 95% excise tax, that funding would dry up for this. And that the job losses would be sudden and immediate, and that over time we would see the loss of cures. One of the reasons I'm important to me is I'm from San Diego, which is the third leading biotechnology cluster in the country. We have about 68,000 jobs directly in life sciences, 175,000 directly or indirectly relying on it, almost 1,000 companies doing this work. Now, so that, of course, we're proud to have Eli Lilly and Johnson & Johnson and Pfizer and those big companies here, and they're important employers, but almost 1,000 companies. That means that there's a lot of small, scrappy entrepreneurs out there trying to rely on risk capital to develop these cures. A lot of autoimmune diseases, a lot of risky diseases. But work's going on every day to solve the really big ones like Alzheimer's, which are expensive and widespread, and the little ones that are so meaningful to the hundreds of people who may have a rare disease, but not as widespread. And that's a real reflection of the importance of American science in terms of jobs here. And I would just say to you that if you're from Michigan, you're for cars. If you're from Iowa, you're for corn. You got to expect that if you're from San Diego, you got to stand up for biotechnology, and I do. But it's not just about the money and the jobs. I want to say, just in conclusion, that it's really about the cures. And I think this Association for Aging Research, but other groups that advocate for the development of cures for things like ALS or for Alzheimer's, lupus, MS, have all expressed concern that we not put at risk this ecosystem that develops these cures by shutting off the faucet of private investment. So the bill that and also would just say that the Disability Council is also concerned that the way other countries keep costs low is that they cut off access, and we don't want to do that either. So the bill that we produced as an alternative to HR 3 would put some of the same caps on what people could spend at the counter. The HR 3 is a $2,000 cap. We did a gradations based on income. $3,100 is the max you could spend in a year. $1,800, $1,200 more relief for the neediest seniors. We also put a $50 a month cap on insulin. We also included an inflation cap, and we started the inflation cap in 2016, so we clawed back profits from pharma over the cost of inflation to pay for this, and it generates at least $200 billion more for investments in other healthcare priorities. And we stopped patent gaming, so that when companies sometimes try to extend out their patent exclusivity beyond the 8 years or the 12 years that's allowed by law, we kind of put an end to that so that there can be competition from generics and other manufacturers. I guess the other thing I would just say too is that we do allow negotiation for Medicare. That's been one of the interests of Democrats, but we make sure that it's tailored for when there's no competition after the period of exclusivity, after people have a chance to get a return, which is what induces that continued investment. So we think it's a good alternative. We are encouraged that it's being discussed by some of the senators who share this concern. The White House has been in touch with us, and we really have to get this done. We want to make sure that seniors don't overpay at the counter. We want to make sure that we don't also disrupt or even endanger the ecosystem that generates these cures, both on the public side and the private side. So I appreciate the support and the chance to explain my position. And I'm optimistic that Democrats will come up with a Build Back Better plan that includes a drug pricing program that meets all of those objectives.
Thank you, Congressman Peters. That was terrific. I just wanted to reiterate one of the points you made. Research America used to put out an annual report. Their last one was a couple of years ago, and I think they're going to be re-upping it in the coming year. But it was looking at R&D investment, and for every $1 of federal investment, there were $3 of industry investment. The rest were from, academic and all that, but just in very small percentages. So I think it's a really important point that gets lost. All right, our next speaker is Dr. Erin Trish, co-director of the USC Schaeffer Center and an assistant professor of pharmaceutical and health economics at the USC School of Pharmacy. In addition, Dr. Trish is a non-resident fellow in economic studies at the Brookings Institution and a scholar with the USC Brookings Schaeffer Initiative for Health Policy. Dr. Trish, welcome, and thank you so much for being with us today.
Thank you so much for the introduction and for everyone for joining us today. Let me just get my screen share going. Okay, well, thank you so much. Congressman Peters did an excellent job of describing the important issues that we're discussing today and the real difficult trade-offs that, these are complex issues with difficult trade-offs with very real and high stakes consequences. And ultimately, that's in large part why the creation of the Part D program was predicated on competition among private plans. Now, I'm sure everybody on the call today is familiar with the fact that there's a pretty significant amount of policy focus and discussions going on around drug pricing reform today. And, the specifics of these various proposals vary, but in general, they kind of share the common sentiment that would have the federal government take a more active role in determining drug prices, or at least many of them do. And that seems to be, driven by a sense that the market is not functioning as it should to constrain prices through competition. And so given that kind of basic premise, I think it's important to take a look under the hood at what we actually have in terms of the Medicare Part D market today. And in fact, if you look at the Part D standard benefit design, what you see is that it's actually the federal government that bears the largest risk for spending once beneficiaries reach catastrophic coverage or reach a high level of prescription drug spending. This is through the federal reinsurance program. This program made a lot of sense. If you think back to 2003 and the creation of Part D, there was a lot of real concern about whether plans were even going to be willing to participate in this kind of unprecedented standalone prescription drug insurance program, and a lot of risk about the financial liability that they would take on in doing so. And so this made a lot of sense to provide a backstop to encourage this market to get off the ground. But what's happened over time is that with the evolution of the prescription drug market since the inception of Part D, we've seen a considerable shift in the concentration of prescription drug spending, so that we're nearing now a significant share of spending occurring among this small fraction of beneficiaries who reach catastrophic coverage. And that means that the federal spending on this reinsurance program has become quite sizable. And in fact, our research at the Schaeffer Center has found that Part D plans, despite the kind of nature or expectation of competition in this market, Part D plans are only actually liable for about a third of the total spending that occurs in this program. And they're particularly limited in terms of their exposure to the high cost or high expenditure region. And that really limits their incentive to kind of effectively or strongly manage spending that happens among the spending and utilization that happens when beneficiaries are in that high cost region. Instead, it's actually the federal government that's directly financing the majority of spending that occurs in this program today. It's also the case that if you look at the evolution of beneficiaries' enrollment in plans over time, we've seen a considerable reduction in the share of beneficiaries that are enrolled in basic plans. And basic plans are important because that's what the Part D competitive bidding design or the program design is modeled around, is really encouraging value and competition among this basic benefit design. What we've seen instead is considerable increase in enrollment in enhanced plans, largely because of the growth in the Medicare Advantage program and also in employer plans, largely because of changes in the ACA. And so what that means is that it's actually a minority of beneficiaries that are enrolled in plans that face these strong competitive incentives today. One other impact or effect that's been, in some sense driven by this benefit design is this increasing presence of rebates or these after the fact discounts paid from manufacturers to PBMs and plans. We've seen considerable growth in rebates as a share of Part D spending over the last decade, and that's really driven a wedge between the list price of drugs and the net price of drugs after these rebates have been applied. What that means from the beneficiary's perspective is that because the cost sharing percentages of the standard benefit design are tied to the list price, and the list price is increasingly not reflective of the net price, the Part D benefit has actually been considerably diluted in terms of what it provides beneficiaries, the protection it provides beneficiaries over time. Research from my colleagues at the Schaeffer Center has found that, in fact, beneficiaries are paying a much higher share of spending when you base it on the net price of drugs. And coming back to the competition point, unfortunately, beneficiaries are most exposed to this overspending in classes of drugs that have the most competition, because that's where the rebates are biggest and this wedge is most significant. So what do we do where do we go from here? Well, fortunately, there are a number of proposals under discussion that would significantly redesign and modernize the Part D benefit structure to give plans more skin in the game so that they would face more risk and have stronger incentives to effectively manage utilization and spending throughout the entirety of the benefit design, particularly included in the catastrophic or high cost spending region, as well as capping patients' out-of-pocket expenditures and their liability to high spending. You might be wondering, though, even if we give plans more skin in the game, is there enough competition there for the taking, or are these just drugs that, that have no competition and there's nothing plans can do? So some research that we've done at the Schaeffer Center indicates that actually the vast majority of spending that occurs in catastrophic coverage is spent on branded drugs that face some degree of competition. And so, in fact, there are opportunities for plans to use their leverage at the negotiating table in these conversations with manufacturers if they're given the stronger incentives to do so. And finally, our research suggests that the real way to make the biggest difference in terms of beneficiaries and where they feel it in terms of their pocketbooks at the pharmacy counter is to ensure that these redesigned provisions, like those included in Representative Peters' bill, base the cost sharing on net price rather than list price, where we found that would make a difference in terms of reducing out-of-pocket costs for about half of beneficiaries who don't receive low-income subsidies in the Part D program, and would also significantly reduce the share of beneficiaries who reach reinsurance or reach the catastrophic coverage to begin with. So just to kind of wrap this up, I think it's important that as we have this conversation, we recognize it in the context of it's not so much that we tried the private market and it failed, but rather that we somewhat failed at trying the private market. These are really important issues in terms of thinking about the cures and the lives and the improvements in health that are at stake. And the consequences of getting it wrong are quite significant. And so I want to kind of provide this concluding perspective that there is a lot to be gained from reforming the Part D benefit design. And through this, we can truly kind of harness the goals of market-based competition in this program and provide optimal value for beneficiaries and taxpayers alike.
Thank you, Dr. Trish. Okay, our next speaker is Michael Ward, who serves as the Vice President of Public Policy for the Alliance for Aging Research. Michael advances research for aging-related conditions through his leadership of the Alliance's legislative and regulatory advocacy efforts. He directs the Alliance's efforts to reduce out-of-pocket costs for patients through Project Lower Out-of-Pocket Costs, also known as Project Loop, and co-leads the Accelerate Cure and Treatments for All Dementias Coalition. Michael also represents the Alliance on the Innovation and Value Initiative, Patient Advisory Council, and the Adult Vaccine Access Coalition Steering Committee. Welcome, Michael.
Thank you, Sue. So we're at a key juncture in U.S. healthcare, and affordability is a key issue. As everyone here knows, the Medicare Part D program for prescription drugs currently has no out-of-pocket maximum for beneficiaries. The significance of Congress implementing a cap cannot be underestimated. According to CMS, 3.8 million beneficiaries entered the catastrophic phase of the Part D benefit in 2019, when catastrophic coverage kicked in once a beneficiary spent $5,100 in out-of-pocket costs within a calendar year. In 2021, the limit to qualify for catastrophic coverage is even higher at $6,550. Much of the discussion on Capitol Hill has revolved around the politics of how much Congress can save to pay for other priorities within healthcare and for other infrastructure. Through Project Loop, we're working to return the conversation to where the focus should always be, to patients. So what can Congress do to address affordability? As we've discussed today, the first is to finally create a Part D out-of-pocket cap for patients. Most prescription drug reform proposals have included a fixed cap, whereas, as Congressman Peters mentioned, this bill would introduce a graduated cap based on the beneficiary income. A cap is important, but Congress shouldn't stop there. Many beneficiaries would still face large lump sum payments for out-of-pocket costs before they reach a cap. This is a real problem. If a patient faces $1,100 in out-of-pocket costs in January or February, they may still face difficult decisions on whether to pay for their medications or to pay for other basic expenses. The impact of these lump sum costs can result in patients not filling their scripts. Earlier this year, research from the National Board of Economic Research found that out-of-pocket cost growth of just over $10 per prescription led to a 23% drop in drug consumption and a 33% increase in monthly mortality, a finding that held true regardless of a beneficiary's socioeconomic status. To address these affordability issues, Congress must pair a cap with a mechanism that will smooth out cost over time, such as through zero-cost installments. Most bills have also included this cost smoothing provision, but in some cases, the flexibility would be difficult to qualify for. H.R. 3's provision on cost smoothing is particularly challenging, as it would require patients to spend $2,000 on their first fill to qualify. This is a key example of how the legislative process must return its focus to reforms that patients will actually be able to access and use. A third option to address affordability, which CMS has included in its senior savings model for insulin, and Congressman Peters would codify for those same patients, is a flat maximum copay for drugs. Congress should explore whether expanding a low-cost maximum copay to other types of drugs would broadly benefit patients with other conditions. Beyond affordability, it's essential to understand the unintended consequences on patients of some of these cost-saving proposals, such as direct negotiation. However, the term really isn't an accurate description. It isn't a real negotiation, it's government price setting. Two cost-setting proposals, H.R. 3's international reference pricing and the rumored consideration of utilization of the Veteran Affairs drug pricing system, share a common flaw: the use of cost-effectiveness standards tied to the Quality Adjusted Life Year, or the QALY. QALY assessments assign a value to the patient population that a treatment is intended for. These assessments are based on the perceived value of living with a given condition in comparison to being in perfect health. The actual impact of quality-based cost effectiveness is big, because if a treatment is for a group that is sicker, older, or includes people with disabilities, or is focused on a population that has historically faced inequities in society and in the healthcare system, the treatment is assessed as being less valuable. Another way of saying it is that these groups are considered more expensive to treat. By concluding that a treatment is not cost-effective, payers can justify restricting access by not covering it or by using management techniques such as step therapy that effectively restrict access. The National Council for Disability, an independent federal agency, and others have shown that quality assessments undervalue treatments for conditions that disproportionately impact people with disabilities and older adults, the very populations that are served by Medicare. Use of the QALY or similar types of metrics would violate civil rights law, and President Biden and the 2020 Democratic campaign platform promised that QALYs would not be used to restrict coverage. However, if we allow the use of QALYs to set prices and then effectively not make the drug available unless that price is accepted, this promise could be broken. Utilizing the VA pricing process would retain these problems. The VA formulary is already more limited than Medicare's formulary. And who helps the VA with creating their formulary? Since 2017, it's been the Institute of Clinical and Economic Review, or ICER, who uses QALY-based and QALY derivative assessments. Not surprisingly, a 2020 analysis of managed care organizations' use of ICER's QALY-based reports in the United States found that 3/4 said that the reports factor into their clinical decision-making. Price-setting policies would also reduce access to new and current treatments. In the US, we have access to nearly 90% of new medicines, while developed countries with price control mechanisms have access to only 47%. The Trump administration's most favored nation rule would have implemented international reference pricing in Medicare Part B. However, Medicare's actuaries found that 1/3 of beneficiaries would lose access to a drug that they currently took within 3 years of the start of the program. So what do we do? One part of the solution should be to develop meaningful alternatives to the QALY and current cost effectiveness frameworks. We also need to advance value-based pricing models that are based on health outcomes that are meaningful to patients. If assessments are not based on what patients and their families care about, then we are not accurately capturing value. Valuations also need to incorporate varying needs and values that are held by different communities. Last month, the Alliance and Project Loop were joined by over 130 organizations on a letter to Congress that outlined the priorities that I've discussed today. There is a clear mandate to address the benefit design and lower patients' costs without turning our back on advancing equity. It is essential that Congress not do what is the most expedient, but to ensure that have the conversation and ensure that they get this right. Thanks, Sue.
Thanks, Michael. Okay, I'm going to ask everyone on the panel to turn their cameras on, and we're going to start with some questions. Our first question is for Representative Peters. At this point, what do you expect Democratic leadership will include in its reconciliation package on drug pricing?
First of all, I think there will be drug pricing. As I think the people have pointed out, there's a need to deal with the out-of-pocket cost issues at the pharmacy counter. And I think that the proposals, including mine, all throw off a lot of extra savings for the federal government to be able to deploy toward other healthcare priorities, whether it's making sure that people are covered by ACA or by, or that the Medicaid gets expanded or things like that. So I think there's a real likelihood that if anything does get passed, this kind of drug pricing reform will be included. Now, you asked me, what's that going to be? I made a comment at the Budget Committee that we're just not ready. We're not ready to vote on this. The premise that I credit the president and the speaker with is that we're going to pay for this Build Back Better Act, or the reconciliation. Analytically, to sort of construct something, you ought to know how much money you have up front. It's very hard to tell what's going to actually be in the bill other than drug pricing until we know what the Senate wants to provide in terms of funding. Once we know that, I think we know how to, we'll know what we have to invest, and we'll be able to do a better job. But I would look for a lot of action by the end of October, when the transportation funding runs out, and there'll be more pressure on us to do another vote.
Okay, thank you. I'm going to ask Dr. Trish the next question. So drug developers try and fail multiple times before they succeed, but government seems to approach drug pricing more narrowly. In other words, they should be paid for the cost of goods sold, and that's it. What's the real world impact of that kind of approach?
Sure, thanks. So, I think that the congressman, laid out these issues quite well in his opening remarks in terms of the response and in terms of the investment in industry, right? I mean, I think this is a very important issue. And there's a lot of academic evidence that, would suggest over the last few decades that the expectation on the return on that investment significantly affects the magnitude of investment that's going to go into developing these drugs. And that this is a risky industry by nature, and we need to recognize that, there's a lot of failures for every one success that comes out of this.
One of the big concerns that Michael raised in his remarks was that HR 3 would base prices here on prices set in other countries, many of which use value assessments that have problematic implications or limit access to medicines. Have you heard from beneficiaries with concerns about these issues?
Yeah, I mean, we've heard from, and also the disability community is concerned about that as well. They've been very vocal about their concern about that. Yes, there's a kind of wonder and magic to the ecosystem that we have in terms of providing cures and access. And I think Michael and Aaron have pointed out some of the ways we can improve it to make the markets work better. We don't have to throw the baby out with the bathwater. And I think that there's ways to do that without there's ways to deal with the drug pricing issue without doing that.
Absolutely. And so as a follow-up, Dr. Trish, what do you consider to be some of the alternative ways to think about assessing value that can overcome the limitations of a price setting type of model?
Sure. So some of my colleagues at the Schaeffer Center have been leading research on ways to kind of better incorporate the kind of risk and uncertainty that's inherent to health and healthcare in terms of thinking about the way that patients actually, express their preferences over the existence of cures and things like that. So I think our methods and tools to kind of quantify and assess value are developing and evolving. But I think the real point here is that it's probably not the case that any one method is going to get this right. And that's why we want to have kind of competing options and give beneficiaries the choice of different plans that think of this in different ways. I think what we want to be doing is encouraging to pay for drugs that deliver on value in the real world, and we've seen examples of that evolving in the market. I think there was a stat news article just in the last day or two describing Pfizer's essential warranty on one of their older lung cancer drugs, right? So if this drug doesn't work, they're going to pay back beneficiaries and the plans, right? That's exactly the type of kind of market-based solutions that guarantee that drugs are delivering on value in the real world that we want to be promoting, rather than making an upfront decision about the way that this kind of does or doesn't present value across the board.
Absolutely. All right, next question. There's been a lot of, and this is for anybody on the panel that wants to answer, there's been a lot of emphasis on keeping premiums low in Medicare Part D. Is it time to consider a trade-off of higher premiums for lower cost sharing?
I mean, I think one of the kind of underlying reasons why premiums have been so low over time is partly the growth of rebates, and that we're really kind of transferring dollars from beneficiaries who are taking these highly rebated drugs. They're paying more at the pharmacy counter to subsidize the premiums of everyone else in this market. And so I think, it's not the case that premiums are low kind of for free, but that's coming from funding sources, which are really beneficiaries are feeling that at the pharmacy counter. And so I do think that presents a challenge for how we kind of get our minds around the fact that, premiums probably need to be a little bit higher to be able to restore the coverage generosity to where it should be today, especially for these beneficiaries taking these highly rebated drugs where we actually see the most competition in those classes.
Yeah, and I'll just add to that. I think, research that we've done, polls we've done with Morning Consult have shown that over half of seniors would be willing to pay a few more dollars a month, $5 to $10 a month just to have some of these protections in place. I think, when you look at the ecosystem of how insurance has evolved, there's been kind of pushing more focus, more liability on patients both, and you definitely see that in the private market through high deductible plans. But I think, as we're serving the Medicare program, especially, people that are on incomes that are fixed, that kind of have, kind of a steady stream of income, but it may be limited. I think we need to think carefully about kind of what what type of costs that we expose them to.
Absolutely. Premiums are considered the sacrosanct that you can't touch. And it's really what the plans compete on. And so consumers are not as, well informed about what's underneath the hood, so to speak. And we actually think that's an area for reform. So next question for Congressman Peters. Would you entertain negotiation in Part D if the excise tax were dropped significantly?
I'd entertain anything. I think that we have to be really careful about this notion of the excise tax at all. It's standard patent law that we provide inventors a certain amount of time to recover their investment. That's kind of the notion of in drug pricing as well. What I've suggested is that negotiation should occur after the period of exclusivity when there's no competition. We've suggested that in Part B, where a lot of the most expensive therapies are, but also where there's an incentive today that I'm sure Dr. Trish could explain better than I to actually inflate prices, whereas in Part D, there is some downward pressure from the market on prices. So, I think that that the negotiation can be used where the markets fail, and that's where I would concentrate it. But this suggestion that we would lower the excise price still implies, I believe, from the question, that we would be regulating prices right from the go. And I think that that's a dangerous message to send to risk capital who are trying to invent these cures.
Yeah, Erin, did you want to follow up on that?
I think, no, that's great.
Okay, terrific.
Oh.
I love when the professor gives me a decent grade. That's great.
Check.
I mean, I guess I will say that, we are starting to see evidence on the Part B side, right? These physician administered and hospital administered drugs, that there is in fact competition coming through the biosimilars market as well, and kind of increasing evidence that that's picking up to deliver value on that side of the market too. And so I think this delineation between, letting the competition kind of evolve as it will in the understanding and recognizing the evidence that suggests that that's happening is an important distinction to make in terms of thinking about the types of policies that the congressman's describing.
And I point out too that one of the reasons that the biosimilars may be becoming more available is that we've extended the period of exclusivity for them to recover their investments. So again, we want to provide the incentives for these cures to come online, and we don't have to be scared of that. I think we should be happy for that. And it's particularly in a year, by the way, when the vaccines that have saved our lives are named Merck, Pfizer, and Johnson & Johnson. They're not named after presidents. And this is a really important part of a public-private partnership that generates these cures. I don't want that to move offshore. I don't want that to disappear. And I think that's clearly I have a little bit of parochial interest representing San Diego, but I really do stand for American science on the public and the private side.
Yeah, and you got to represent your district. All right. One question that's more specific to your bill, I think this is a good one. Your bill would negotiate drug prices for Medicare Part D drugs that are off patent but don't have a generic competitor, which is a narrower universe of drugs that would be affected than HR 3. How do you address criticism that your bill would have comparatively minor impact on overall drug prices for consumers?
Well, that right off the bat is wrong. A consumer, we won't want consumers to go to the pharmacy counter. Also, I think Michael mentioned smoothing. We have that in our bill as well. Maybe our process could be improved, but we want consumers to feel that when they go to the pharmacy counter, they can afford their drugs. And actually, in many ways, our bill gives more relief to consumers by setting a lower threshold for low-income seniors at $1,200 a year than HR 3, $50 a month. $50 a month limit on the expenditures for insulin and a cap on inflation. I don't accept any suggestion that my bill gives less relief to consumers than HR 3. If anything, we do better. So that's one thing. Two is the criticism I do here is it doesn't throw off as much money for other things. And okay, that's probably true. That is true. but I'm not willing to pay the price of losing American science to do that. I don't think we have to provide consumers relief. Democrats promised consumers, patients relief at the pharmacy counter. Every single one of us is going to deliver that. And my bill would deliver that just as well, if not better than HR 3. And just the minor thing is the question talked about negotiation in part D, Delta, where actually my bill is B, Bravo, not D. We were just talking about that too, just to make sure we're clear. But that's, this notion that we're not providing relief to consumers is just flat, manifestly wrong.
Yep. I think it's also just really important to make the point that you're going to be cutting access, and there'll likely be shortages too. I mean, we all experienced this in the those of us who remember in the late 70s with gas prices and oil sitting in those long lines. And it's likely to have a similar effect with pharmaceuticals. And folks don't want to have shortages. They don't want to have to, give up newer treatments and new cures. So there's a lot of impacts that even go beyond the innovation piece and where folks are going to be getting their business from. So this next one is for everybody on the panel. What is the role of PBMs and insurance companies in setting the prices actually paid by patients at the pharmacy counter? And what can be done to counteract the influence of these supply chain intermediaries to the benefit of the individual consumer? I'll start with you, Erin.
Sure. So, I think ultimately the PBMs and insurance companies are the ones who are, negotiating formularies and determining what cost sharing patients will face at the pharmacy counter. PBM industry in particular is a highly concentrated industry. And as we've described in several instances across the conversation today, there's a lot of perverse incentives related to essentially inflating list prices or negotiating for higher rebates rather than lower prices that are kind of lower cost sharing for patients at the pharmacy counter. I think there's a number of provisions included in Representative Peters' bills, other bills that would increase transparency in this market and would try to improve essentially the functioning of this supply chain. We've done a lot of work about the significant share of the dollars that are spent in this market that are actually captured by these intermediaries and not going back to the innovators. And I think the goal of this is to try to increase the competition in this market to try to make it better function and to deliver that value to the patients rather than some of the intermediaries.
I think from the patient side, as Erin mentioned, there is the way that we have it now, where the beneficiary share of co-insurance is based on the sticker price rather than the price that their plans insure is actually paying for the drug. Does kind of strikes me as being very non-patient centric. And so I think as we're approaching drug pricing reform, yes, prescription drug companies need to come to the table, and they have a big part to play. But we also need to realize the role of PBMs, of insurers, of groups throughout the ecosystem that kind of touch a prescription drug, from the point of its creation to the point that time gets to the patient. And also, they all have a role in helping reduce drug costs and make sure that they remain sustainable.
Congressman Peters, the last word on this before we wrap up.
I don't have anything to add to that. Those are pretty smart academic comments. I don't want to dilute.
Okay.
Yeah, I just want to flag, that I think that's kind of something unique about your bill is that we haven't seen kind of that approach to basing cost on net price rather than on list price in other proposals. So, I think that's a key differentiator and would create, as Erin, as Dr. Chris talked about, would create a fair bit of savings for beneficiaries, in addition to the cap, in addition to the smoothing provisions that we talked about. So I think it's a really important provision.
Absolutely. Well, thank you to Congressman Peters, Dr. Trish, and Michael for their insights today. And thanks to everybody here for joining us. A recording of today's webinar is available on the Alliance and USC Schaeffer's individual Facebook pages, which we encourage you to visit and subscribe. And the recording is also going to be available on the Alliance and USC Schaeffer's respective YouTube pages in the coming days. We thank you for joining us for today's program, and we look forward to continuing the conversation. Have a great day.